Good afternoon, everyone. My name is Cesar Alvarez, and I am a Legislative Associate with NCAI, and I'll also be your web administrator today. On behalf of the National Congress of American Indians, I'd like to thank you for attending this presentation on developing national guidelines and building research capacity to support intertribal communities, which is a part of our NCAI Diabetes Translation Webinar Series, the first of three. Before we begin the presentation, I'd like to go over some of our webinar features. First, you should see on your screen the PowerPoint for today's presentation. If during the presentation you experience any lag in slide transition, it may be a result of internet connection. So just give it a few extra seconds to update on your screen. Currently, with the exception of panelists, all audience phone lines are muted until conclusion of the presentation. But if you would like to ask a question, you can type it in the questions box on your webinar control panel. After the presentation, we will have a Q&A session, and panelists will answer questions submitted through the questions box. If you'd like to ask a question over the phone, please use the raise hand option so we can unmute your phone line after the presentation. Also, our webinar software archives all questions submitted through the questions box. So if we are unable to answer or address your question, we will follow up with you after the webinar has concluded. And finally, this webinar is being recorded, so we can show this presentation with you and others not able to attend today. And with that all said, I'll turn it over to our moderator, Dr. Malia Villegas of the NCAI Policy Research Center.
Thank you so much, Cesar. Good afternoon, everyone. Good morning to those of you logging in from further west than we are here in Washington, D.C. Thank you so much for joining us. I just want to give a little bit of overview and background about the NCAI Diabetes Translation Webinar Series. As Cesar mentioned, this is the first of three series events that we're hosting. The next one will be this coming Friday from 2 to 3:30, and then the last one will be next Tuesday from 2 to 3:30 Eastern Standard Time. Some of the background is that NCAI is a part of one of the Centers for Diabetes Translation Research, or CDTRs, funded by NIH, specifically NIDDK is the center there that's funded these. And of the 7, 3 have a particular emphasis on American Indian Alaska Native diabetes, and we are one of those 3. So we're very excited to feature some of the most cutting-edge research in order to meet 2 goals. One is to prevent obesity in our communities and to reduce health disparities through the use of research. A key part of that is to explore the unique aspects of translation in Indian country. And so we're in the process here of developing a translation guide for use in American Indian Alaska Native context specific to diabetes. And there are 4 elements that we are going to be highlighting as part of that translation guide based on our feedback from tribal leaders and scholars in the field. Those 4 aspects include policy advocacy. Many of our network partners tell us that if you're going to improve the context of health related to diabetes, you have to engage with policy, such like the Special Diabetes Program for Indians that's funded here at the national level. The second element is co-occurring conditions. Looking at diabetes, but understanding how prevalence of diabetes connects to cancer rates, connects to oral health, connects to other kinds of disease and conditions that we see in Indian country. So we'll be developing some work about that. The third area, besides policy advocacy and co-occurring conditions, is outcomes. Really not just looking at peer review publications as the only outcome of impact that we're trying to advance, but really thinking about replication and adaptation of interventions like the Diabetes Prevention Program in our communities that have more meaningful impact that way. So looking at the range of outcomes. And finally, really trying to understand research guidelines and regulation, and that's really where this conversation today is focused here. We're very excited to have our partners at the National Council on Urban Indian Health leading the way, Dr. Jamie Barkas, and her colleague, Dr. Nicole Yuan from University of Arizona. So I'm going to turn it over to Dr. Jamie, and we're very excited for this presentation. Go ahead, Dr. Jamie.
Thank you, Malaya. Again, my name is Jamie Barkas. I'm the Director of Technical Assistance and Research at the National Council of Urban Indian Health and a citizen of the Cherokee Nation in Oklahoma. I'll do a very brief introduction of myself, and then I'm going to turn it over to Nicole to do the same. I'm a clinical psychologist by training and have worked in direct patient care in all 3 parts of the Indian healthcare system, in addition to supporting a wide range of community-based research and evaluation projects across Indian country. I'm excited about this topic today. It's something that's very important as we work to improve the health and well-being of all of us as American Indians, no matter where we reside, and looking forward to getting some feedback from those of you on the call. So Nicole, if you could also do a quick introduction of yourself before we get started.
Sure. Good afternoon. We appreciate your interest in this topic and look forward to some productive discussion at the end. My background and training is also in clinical psychology. I'm an assistant professor at the University of Arizona in the School of Public Health, and my research areas of interest include interpersonal violence, alcohol use and abuse, and American Indian mental health. And I've had the pleasure to work with Jamie on some of these issues, and we're currently working on a manuscript to document some of the ideas that we are presenting to you today. So we look forward to hopefully receiving some of your feedback and input. Thank you.
Great, thanks. So could you transfer to the next slide, please? So we wanted to start by providing a few of the objectives that we have for the webinar. First, we'll describe a little bit about the history of the partnership between the National Council of Urban Indian Health and the University of Arizona, so that you kind of understand how we partnered up and for what purpose. And then we'll also talk a little bit about the need for data collection among urban communities that are serving American Indian, intertribal American Indian Alaska Native people. We're also going to talk a little bit about some of the unique considerations for conducting research in those settings, and ultimately we'll list recommendations for engaging a number of different stakeholders to really promote research in those urban settings. And then finally, this is the part that I think will be most helpful for us, is to get any feedback from you all based on the recommendations that were made through this presentation, as well as any feedback that you have and things that we might have missed or other ideas in terms of moving forward. Next slide, please. So first, let me tell you a little bit about the history of the partnership between the National Council of Urban Indian Health and the University of Arizona. Back in 2002, we were actually contacted by one of the urban Indian health programs, the Tucson Indian Center. And the Tucson Indian Center, for those of you who don't know, is a Title V urban Indian health program that is providing a wide range of services to American Indian Alaska Native people living in the Tucson area. And they're serving tribal members from many, many, many different tribes. And they really reached out to us to request that we work with one of their faculty partners, Nicole, at the University of Arizona, because one of the things that was happening is they were trying to engage in some community-based research work together. There were policies being considered within the Institutional Review Board at the university that were really considering that tribal approval be required for any research conducted with American Alaska Native populations. And of course, the Tucson Indian Center serves tribal members from about 42 different tribes. We actually have some urban Indian health programs that are serving citizens of hundreds of different tribes. And so I'm sure that you can imagine getting approval from 42 different tribes would be maybe all but impossible. So we partnered with Nicole to examine the available research and policies that were related to conducting urban Indian health research. And as a part of that, we recognize that there really is not a lot out there, although there have been some national meetings of stakeholders interested in urban Indian research. There really hasn't been anything available in terms of setting those guidelines and policies for conducting that type of research. So one of the things that we did is we drafted a manuscript that's really focused on this topic because, of course we need to support research to ensure that those people living in urban areas are being supported and we know what works in terms of best practices for their health care and services. At the same time, there's a need for protection and to make sure that they're they don't become a sample of convenience and other things which we'll talk about through this presentation. And so right now we actually have a revision in progress for a peer-reviewed journal, and this manuscript we hope will really start setting the national dialogue around guidelines for urban Indian research. Next slide, please. So as many of you probably know, there's really a need for data for a number of different purposes. The first is just understanding those local needs. You know, what are some of the challenges, the health disparities, the other factors that may impact people's ability to either access care or what types of things do they need in terms of quality and culturally competent care. We also really need some support in documenting best practices. What works within a rural setting may not be the same that in terms of what might work in an urban setting where the geographical context is quite different. Of course, data is also important to educate our communities so that people know what's happening, as well as you know, how to maintain health and well-being. And then, you know, data is really critical for us making the course correction. So, you know, that's one of the beautiful things about data, is that it gives us the opportunity to continue to improve the work and the services that we're providing. And then finally, you know, data is very critical for leveraging resources so that we can continue to address the needs of the community and continue to build services that are going to best support them. Next slide, please. So one of the things that we did just to kind of start the development of the manuscript is just to try to get an idea of what knowledge was available out there in the academic world. Now, while we didn't look at the quality of that information, but we were looking at kind of the quantity of it, how much data and research is out there in the health field on urban Indian populations. Back in 2009, which is about a year before I came to NCAI, the organization, through work with the Association of American Indian Physicians, actually did a knowledge map, and they partnered with the National Library of Medicine and the University of New Mexico to do a search of academic literature that existed on urban Indian health. And at that time, what they found was that there really wasn't a lot of research that was out there. And so in April of this year, we actually replicated that process in terms of the knowledge map. And all we did was we did restrict our search to PubMed, which we were hopeful would capture any research that was published through NIH support. And we did simply two things. First is we looked at the keywords tribes and American Indians, and we actually generated 4,421 articles in about a 10-year time span. And then we also used the search words urban and American Indian, and we generated a total of 343 articles that were published within that same time span. Next slide, please. So of those 343 articles, only 181 of them actually included a sample or a focus for American Indians living in U.S. cities. So some of them were outside of the United States, and some of them, when we really started digging in, were not actually urban Indian samples. And of those 181, there were only 127 articles that actually generated new data, either qualitative or quantitative, and that was either done through a primary data collection or it was a secondary analysis of an existing data set that actually generated data related to urban Indian populations. And the reason why we restricted it to that is we really are looking at not just concept papers or position papers, but we really wanted to know what data was being generated about urban Indian health. And those 127 articles included a wide range of health, behavioral health, public health, and, as well as social determinants of health research. Next slide, please. So even more concerning is that out of those 127 articles, only 8 of them were on diabetes research with urban American Indian population. And you can see the list of topics that were included. And so you can see that there's just a real lack of at least publications that are conducted with urban Indian samples. Now, and again, if we had expanded our search engines to include others, we may have, this number may have increased some, but it's still quite a small number, considering that many of the studies abstracts are included in PubMed. Next slide, please.
I just want to reiterate there, Dr. Jamie, that's less than 1 per year, correct? That's 10 over the course, 10 years, 8 over 10 years.
Yeah, that was a 10 years time span. So that was from 2003 to 2013, April of 2013. And so then I wanted to also make sure, because not everybody recognizes that there are disparities that American Indian people are facing in urban settings. And we were able to, pull together a lot of the data that's coming out that's really much more epidemiology in focus is coming out of our Urban Epidemiology Center, the Urban Indian Health Institute, and they actually have some really good publications where they have been able to kind of analyze data, do secondary analysis of data sets, national data sets that exist. And as you can tell, there are some pretty serious disparities that that American and Alaska Native people living in urban settings, at least nationally, are facing. We do know that there is a lot of poverty still. You would think that living in an urban area would have access to more jobs and opportunities, which in many ways is the case, but when you compare to urban counterparts with the cost of living and other factors, there's still a high rate of poverty among American and Alaska Native people living in urban areas. We have about 11.9% of all American Indians living in those areas diagnosed with diabetes, as compared to 7.8% for all races. We also have a high rate of death by alcohol-induced causes. National survey data also kind of sheds light on some of the issues faced for these populations related to violence. And one of the things that we were quite surprised to find is that about 17% of all urban Native women actually had a first sexual intercourse that was non-voluntary. And that actually kind of mirrors when they looked at youth data. And of course, these surveys were kind of worded a little different. So you can see in the 16.4% of urban youth were forced to have unwanted sex. Again, that's just how the survey was worded. But you can see those rates are pretty similar in terms of having non-voluntary or unwanted sex as a first time. And then the other part, too, is that we have some concerns around the suicide rates and other things within the population. About 20% of urban Native youth actually have a history of a suicide attempt, and in one of the surveys, about almost 11% of those who had a suicide attempt in the last year requiring hospitalization. So this just wasn't a minor attempt, but it was an attempt that required them to go to the hospital, which is about 4 times the national average. So in urban, this is just a snapshot of some of the data that was available, but there is a real, definitely real disparities that are occurring, and this really highlights the need that we have research conducted in urban Indian populations, not only to make sure that we understand what's happening, but also to determine how do we address these things and what are some of those best practices in health. Next slide, please. So some of the unique considerations for research in urban Indian populations, the first really is that in in an urban setting, American Indians oftentimes become invisible. And just last week I was listening to a presentation from one of our urban programs that was out in the San Francisco Bay Area. And it was interesting because a parent, a native parent, was talking about how her daughter was walking down the hall of her school and overheard some kids talking in the classroom, and of course November being Native American Heritage Month, overheard some kids talking in the classroom saying, there aren't any American Indian people here anymore. And here she was walking down the school, going to school there, and having kids within her school not thinking that there were any American Indians that existed. And so that invisibility is pretty big in urban areas, particularly when you're maybe 1% of the population. And for a lot of the Native kids, they may be the only Indian kid in their school, depending upon where they're at. But in places like Los Angeles or New York City, where you're 1% of the population, you pass people on the street and they really don't know, they may not know you're American Indian, and oftentimes will think that you're from some other ethnic community. So that becomes a challenge in terms of identifying those folks for participating in those communities. And then mobility also is an issue, and I'm troubled that I can't find it anymore, but the Indian Health Service many years ago actually did have something up on their website that was looking at, they had actually analyzed the RPMS data, and they were looking at the percentage of patients that were within a certain time period seen both within urban settings as well as within a tribal or Indian Health Service setting. And the mobility rate at that time was quite high. If I remember correctly, it's about 1 in 4, so about 25%. But we do know anecdotally that our American Indian people living in urban areas oftentimes go back and forth between the urban setting and a tribal or rural or reservation setting for healthcare services. And you know, from my community where I'm from, people will pick and choose which facility they want to go to based on what resources are available at that facility. So we do know that the mobility is quite high, so it becomes a bit of a challenge in terms of conducting research when people are moving back and forth. Also may be challenging in terms of determining, you know, do they meet the criteria for really being an urban resident when they're migrating so much. The other challenge that we have is that there's no sovereign body to build a partnership with. Now, while our urban Indian health programs that are funded through Title V of the Indian Healthcare Improvement Act, they're required to have a majority Indian board of directors. They're not a governing body. They're not a government. So there's challenges in terms of building some type of partnership with some sovereign body that just doesn't exist. Whereas if you're working with a tribe, you can actually work with the tribal leadership and work through the tribal government to make sure that, you know, you've got approval and permissions to do those things and that they're consistent with what that community wants and needs. But in urban settings, that becomes a little bit more challenging. And along those lines, we also still need cultural protections when there is research being conducted in urban Indian populations. The last thing that we want is for research to, you know, be conducted in with urban samples because it's convenient. We certainly don't want there to be kind of a sample of convenience, and that definitely has to, you know, could be the case when when you don't have a sovereign nation that's saying, hey, you've got to get our, you know, approval and permission before you do this. So that's one of the unique things is that we don't have a sovereign body, but yet we still have that need for cultural protection so that American Indian people, you know, that there's no misabuse or misuse. And then the other challenge that we have is that in urban settings, particularly if you're a long ways from your tribal lands, it becomes challenging to access cultural and spiritual resources, and that includes food. And, you know, while many of the urban residents that have resources will travel home to participate in their ceremonies, their spiritual gatherings, to go home to access those kind of cultural resources, many of them don't have that luxury because of their resources. And again, kind of going back to knowing that, you know, many of the urban Indian people are living in poverty, it makes it limiting for them to be able to access those cultural and spiritual resources. And then another really challenging thing for us, which we've kind of identified already, is that there's such diversity in urban Indian communities because there's so many different tribes represented, and all those tribes are very unique and different. Now, while there are some commonalities that kind of tie many urban Indian people together, one, they're living in the same context. They have a lot of the similar issues related to invisibility. They oftentimes in certain cities will experience racism in similar ways. And then, you know, having the lack of access to their tribal lands for that kind of spiritual, cultural nourishment. You know, those are kind of themes that may tie intertribal people together, but they are all very different. And even when they come together in urban areas, you know, whatever they do that's culturally based, you know, it may not work for everybody because of that diversity. And then the other part, too, is that it's important to recognize that we are seeing, at least from some of the data that's being presented, some pretty high rates of violence. And I only presented a snapshot of it. There's quite a bit more. Some very high rates of violence. And that is maybe a little different than what I think about back home. Because, you know, back home, usually if there's a violent incident or event, you usually know who it is, or you've got some relationship, or you know who they are at least. Whereas in the city, you've got that interpersonal violence that occurs, but there's also this random violence that kids just grow up in and become used to. And, you know, I think of my own migration out of my, you know, tribal community to go to school and work, and, you know, the first time I saw someone get held up at gunpoint, what a shock that was for me, a random thing. And so those kinds of things are pretty common in the city, which makes it a little different than what you might see in rural settings. Next slide, please. So one of the things that I wanted to do, because in addition to looking at the knowledge map, what kind of information is, or how much knowledge is out there in the academic world related to urban Indian health, and, you know, looking at the disparities that we were able to identify that existed. One of the things we did was we tried to look at some case studies of urban Indian health programs that had partnered with academic institutions to attempt to conduct research. And so one of the case samples that we are showing today, and we're not going to show all of it, but we're going to give you just a snapshot of what we're talking about. The Indian Health Center of Santa Clara Valley is one of our Title V urban Indian health programs that's serving the San Jose area. They actually partnered with Stanford Prevention Resource Center. And this has been about we've been working with them about maybe 5 years, so it's been a long time in the making, but they are at a place now where they were able to submit an application to the National Institute on Minority Health and Health Disparities for a very innovative diabetes prevention program that looked at historical trauma as a part of that. And the reason why they really focused on that is because they were finding high rates of post-traumatic stress among their pre-diabetic patients, and recognized that there was something significant happening. And if you think about it from a conceptual framework, you know, when you've got a history of trauma, there's a lot of trauma occurring either historically or intergenerational trauma that's happening, it really does kind of stifle you, and it impacts your ability to do things like get out of bed in the morning and, you know, focus on making a healthy dinner and getting your exercise in, and that started thinking about it conceptually. And so they submitted, and you go ahead and next slide. They submitted this application, and they went through the standard NIH review process because urban Indian health programs are not eligible for NARCH or any other mechanism that would allow them to have a, you know, culturally relevant or specific review. And so they went through the the main mechanism, just straight competing with, I guess, everyone else. And they got back an NIH review that was quite troubling to them. And we're just showing one of the troubling comments that came back from that review. But what happened was it really helped us to understand that the reviewers knew very little about urban Indian populations, and that there were some pretty insensitive things that were really challenging, I think, for community, and I'm thankful that they're willing to share this review with you all. But as you can see here, the reviewer was really questioning historical trauma as a concept, which that part's fine, but then you move down and see that they're asking about half-breeds and mixed bloods in terms of their historical trauma history, and it was just very disheartening to the community. Other reviewer comments included comments about pan-Indianism, which can be a real blow to in urban context when they're so maybe thousands of miles away from the tribal lands, and they try to find some way to come together, and it may not be their ways, but they're glad to just come participate in somebody's ways. And we see that, typically whatever the local tribe is, those ways will be the most prominent. So for example, back in Oklahoma, a lot of the northern folks had to come and participate in our stomp dances if they wanted to involved in local things, and then you'll see variations depending upon which tribes are in the majority in that area. But there were some really disheartening comments that came back, and it really shed some light on for us that there really isn't a good mechanism for urban Indian communities to access, funding for research projects that might really make a difference. Not only this particular study, not only make a difference for urban Indian populations, but could have huge implications for tribal communities as well. Next slide, please. So as we move into the recommendations piece, I wanted to, this was a really challenging process because we recognize that we've got some diverse stakeholders that really play an important role in this. And so in the recommendations, we actually make those recommendations by stakeholder group. And those stakeholder groups that we primarily targeted include urban Indian health organization leaders, tribal leaders, research scientists and administrators, and policymakers. Of course, there may be other groups that could be included, but this is really kind of where we focused. At least the first paper is targeting those stakeholder groups. Next slide, please. So to start, we really do see a role of the urban Indian health leadership and those urban Indian health organizations as kind of an organizing body to support research conducted in community or in their local urban settings. But there are several things that we think that would be important for those urban Indian leaders in terms of thinking about how they could support the research to be done in a culturally respectful and appropriate way. The first is, as we've already mentioned, the last thing we want is for people to say, or research to say, well, we have to get tribal permission if we do research with a tribe. But in urban settings, we don't have to do that, so that's just more convenient. So we don't want it to become, that urban Indian populations are a sample of convenience. So one of the things that we've really promoted is thinking about how urban Indian leaders can actually really support protecting the rights of American Indian people and their tribal cultures. And we really believe that partnership with tribes that are, that the Urban Indian Health Organization is serving their citizens is a really important step. Now, while you may not be able to partner with all of the tribes, and some of the tribes may not have the infrastructure to be able to help out, that those partnerships are important just to make sure that, because, you can't be an expert on 100 different tribes, so it's really important that you're linked in with those tribal entities that are around you when there's research that's going to be conducted that might have some cultural implications. And then, so that's one of the recommendations that we have for the urban Indian health organizations. And the second thing is, we're noticing that there's a real need, and this may be the same in rural or tribal settings as well, but there's a real need to build up the organizational capacity and the infrastructure for conducting research. And with the example that we just provided with the Santa Clara Clinic, I said it's been a 5-year process. We started with them kind of just helping them understand their baseline data about 5 years ago. And so typically it starts very slow, where it's just getting them to see data, understand what it means, use data, then start thinking about how it could be used for continued quality improvement, and you kind of go through a whole, evaluation process, use of data, and then finally you might be able to get to a place where you have a unique research question and you actually can move forward on a research project. So it's a very slow process, but really supporting that kind of organizational capacity for conducting research, which again usually starts with evaluation, benchmarking and evaluation. And then also there are national resources that are available for research and technical assistance. At the National Council of Urban Indian Health, we're oftentimes providing technical support to those urban Indian health organizations in developing strong university partnerships, in improving their local data collection, in developing plans for evaluating programs, as well as consultations on implementing research with university partners. And then there are others, through many of the grants that urban Indian health organizations receive, there are also oftentimes research and technical assistance support through those sources as well. And then also we're really working with those urban Indian health organizations to establish partnerships with their area academic institutions and really trying to find those culturally competent researchers. It's really tough to find American Indian researchers. There's not a lot of us around the country, and we kind of all know each other, but when there's not an American Indian researcher available, really trying to find someone who's culturally competent and who understands community-based and participatory process and will kind of commit to that. Those are the partnerships that we're really trying to, support our urban Indian health organizations in building. Next slide, please. For tribal leaders, one of the things that we know just by looking at data over the course of time is that the migration of American Indian people into urban settings is continuing, and that growth has continued over the course of the last several decades. And of course, as when thinking about the majority of American Indian Alaska Native people residing in urban settings, that link to our tribal communities is very important, and those urban citizens become an important part of the sustainability of the tribal nations just because of numbers, and thinking about how the urban Indian communities can still become linked to the tribes. And I'll provide a couple of examples of that here in just a minute, but really thinking about how tribal leaders can really strengthen those relationships with their urban residing citizens. And there's a wide range of things that they can do, in addition to providing education and resources. Here's a few examples of some of the partnerships that are currently in place. The Navajo Nation has actually provided some funding to the Friendship House of American Indians, which is a residential treatment center that's very culturally grounded. It's very holistic in their approach. And that allows the Navajo Nation to access residential care for their citizens when they need it through the Friendship House of American Indians in San Francisco. So that's one partnership. The Indian Healthcare Resource Center in Tulsa actually partners with Cherokee Nation to provide WIC services to the folks living in the Tulsa metro area. And then we've actually had other tribes, like the Anakim actually supported through the Los Angeles community. They had a lot of citizens in Los Angeles supported linking cultural resources to those citizens by streaming radio from the tribe into Los Angeles in the tribal language. So, there's a lot of examples of language partnerships and other things between urban Indian health organizations and tribes. And it's a great way for the tribes to keep their reach into the city where their citizens are residing. And it's also a great opportunity for tribes to educate their citizens about research, And I always have I think about within our own community, we have a newspaper that has been going on. This paper has been pressed for well over 100 years. It actually started in press before the state of Oklahoma was even thought of. So we've actually had a written newspaper for for a long, long time. And that newspaper serves as a forum, and even as me living outside of my tribal lands now, I still get that newspaper. And that newspaper is an important way to announce things to communities. And that's a great forum to be able to think about how to educate community members to be good consumers of research, as well as participating in research in a way that's going to be culturally respectful. So those are nice forums if you think about it. And thinking about how, as American Indian people, we're all from the same. When we're from some tribe, it doesn't matter where we live. We're still important to the sustainability of that nation. So those types of partnerships may be helpful in thinking about promoting culturally competent and quality research, as well as protecting the cultural resources and rights of tribal people. Next slide, please. So we also focused on, in the manuscript on the role of researchers and academic administrators. And some of these are common recommendations that come forth a lot, whether they be tribal or urban Indian communities. The first is really thinking about how you can implement diverse and innovative research methods that are really culturally appropriate and are highlighting local issues. And the sample that we gave from the Santa Clara Clinic, it was very much grounded in what they were experiencing there locally, and the process that they took using a strong community-based model really helped their process in terms of being able to submit that application. And of course, sometimes the methods that we are asked to use, or we struggle with, particularly when there are issues related to randomized clinical design and other things, when you have to make decisions about who gets the intervention and who doesn't, particularly when people really need it. Applying participatory research principles is very important for American Indian populations, and again, that doesn't matter if it's urban or tribal. That's a very important recommendation that's made in many, many forums. And then we also mentioned the importance of having tenure criteria, promotion criteria that really recognizes that excellence in community-engaged scholarship. Because one of the things, I think in the academic world, in the pressure to publish, community-based research and participatory research just takes longer. And it oftentimes takes so long that it's difficult for tenure-track faculty to engage in that type of research. So if you could update your promotion and tenure criteria to really allow for community-based projects to be a part of that, that would be helpful in promoting that type of research in communities so that you're actually meeting their needs in terms of what they want and need for research. And then finally, as we kind of began when I was talking about our relationship with the University of Arizona and how we kind of came to be partnering together, the use of culturally appropriate institutional review board policies is very important. Again, when you're thinking about working with American Indian Alaska Native people living in urban areas, if you've got like the Tucson Indian Center, 40-some different tribes, it's not feasible to ask for permission from 40-some different tribes. So creating some mechanisms or policies that would ensure that those populations, American Indian Alaska Native people in urban settings, are not being taken advantage of, but at the same time that you're not interfering with the ability for research to actually be conducted. And then also, and this again goes for both tribes and urban areas, developing culturally appropriate university contracts. And this is particularly around intellectual property rights and the ownership of data and how that comes out in terms of publications. And this is a really challenging one, but it's very important if you're really going to be doing community-based research that, the primary goal is that the data is going to benefit that community and that the data comes back to that community in ways that are going to be helpful and useful. And then also honoring the fact that whatever it is you're collecting as a researcher, whether it be blood samples or knowledge or experiences or whatever, those experiences, knowledges, and specimens, whatever they may be, do belong to those people. And so thinking about how you're developing policies that are going to be supportive of CBPR particularly related to intellectual property and publications. Next slide, please. And finally, the role of policymakers. One of the things that we really are recommending is that there be increased interactions with the urban Indian health organizations, with tribal leaders, and with research scientists and administrators, and making sure that there's a clear understanding about what the challenges and issues and needs are. Working for NCAI for the last 5 years, I continue to educate federal partners about who the urban Indian communities are and what that looks like, but I continue to have them, even after education, they still call the urban Indian health organizations tribes. So I always have to remind them that urban Indian health organizations are not tribes, they are not sovereign entities, and they are set up a little different, and the way you work with them would be very different than you work with the tribal government. So I think having those kind of interactions and making sure that when those meetings are scheduled, that there are a nice representation of the urban Indian organizations as well as tribal leaders as well. The second, really advocating for increased funding and resources. We again, you saw the dearth of literature that is available. We've got 8 articles in the last decade related to diabetes with urban Indian samples. We really do need increased funding and resources to support that research. And I think the same could be said for tribal communities, just accessing research dollars for community-based projects is really important. The other part, too, is that it's very important that we get a culturally appropriate scientific review. It's tough for us to know, and I only showed you one comment. There were many. It's tough to know whether or not, because the project was not funded, whether or not those comments impacted the funding decision. But it was very disheartening, and it's hard, I think, because even you think about it, we're not separate from our communities. When we get these reviews back, we have our own historical traumas, and it hits us pretty hard. Oh, I can't believe that this was said. So making sure that those scientific review processes are appropriate. And then also, we have a very small number of American Indian scientists. This has been the ongoing topic of tribal consultation with the National Institute of Health for the last several years. Through that consultation process that occurs usually the big meeting in March. And there is a real need to increase the workforce of American and Alaska Native scientists, both through educational programs and through scholarship. There's really not a lot of AIAN scientists that are being supported, and it's really important that we start growing that workforce. And then finally, using the research findings to inform policies. It's really important that that research makes it back into policy and practice. And I know that that may be speaking to the choir for some of you, but knowing what the gap is between the publication of a research and whether or not it ever, how and when it ever gets implemented. So it's important that those policies are being linked to what we know in the research. Next slide, please. So the next steps for us really is we're in this process now where we're just seeking feedback and trying to determine whether or not we have thought of all the things that we need to include in terms of those recommendations, and really starting to encourage some open dialogue among new stakeholders around national guidelines for urban Indian research to establish those guidelines. And then once we have publications out, it's really important that we're able to disseminate those, as well as implement some of the strategies and then evaluate whether or not they work. So that's one of the things I think is always important as you're developing guidelines, is that you check them out to see whether or not they actually are effective. Next slide, please. So I do, before we move on to the Q&A session, which we're coming up on, I did want to have some acknowledgments. We actually had, we do have a co-author that's not on the the line with us today, but we do want to acknowledge her, Deidre Demers, who was a student at the time when she first got started with us there at the University of Arizona, as well as some internal reviewers that we had prior to submitting the manuscript for publication. Mr. Ralph Vaquera, who's the director for the Urban Indian Health Institute, which is the Urban Epidemiology Center, Dr. Joe Gahn, who is a well-known researcher, an academic, Dr. Jenny Joe, and Dr. Dolores Bigfoot, who all have significant contributions in the research literature and have all supported research within urban Indian context and populations and topics. So we want to thank them for their review prior to submitting for publication. And then we also had a number of institutions that were involved, including NCAI and University of Arizona, but want to send out a thanks to the Tucson Indian Center for helping get this started, addressing these issues, as well as the Indian Health Center of Santa Clara Valley and their team there at Stanford for being so willing to allow us to share their experience. Next slide, please. So we are now coming to the Q&A session, and we're hoping that we could have some discussion. And we have a few questions that we developed just to try to start with discussion points. In addition to any comments or feedback you might have about the recommendations that were made to the various stakeholders, we're also interested in if there are things that you think might be missing. And then we also have some real interest in thinking about, and kind of going back to this issue of the fact that urban Indian health organizations, while they can provide some organizing role and connection to the community and, kind of coordinating some of the research that's conducted, thinking about how they might be able to help protect against research that might contribute to cultural misuse, abuse, or misrepresentation. And this may be a real issue if they've reached out to area tribes and maybe the tribe doesn't have the infrastructure or human resources to address these issues, thinking about how it is that they might be able to protect against these things. And I think the same could be said for like an institutional review board that's trying to set up a policy related to this. What are some ideas about how how culture can be protected? And then finally, we wanted to think about what next steps that we might be able to take to really ensure that urban Indian research guidelines strengthen the diabetes translational research. So any ideas you had about that? And at this point, I'm going to lean on both Nicole and Malaya to join in this discussion session, and I guess turn it back over to you all over there at NCAI, because I don't know if you open the lines or how you do it over there.
Sure. Well, thank you so much for that. I just want to give a couple of quick overarching kind of points of feedback, because there is just a lot of richness in that from where I'm sitting. And then I think we're going to have Caesar go through a few of the questions that have been raised while you folks were presenting, if that makes sense. Mm-hmm. So just a couple of thoughts. I think I did forget at the beginning to acknowledge our partners, and so that's my oversight, Washington University in St. Louis. I think a few folks are on the line with us. I want to acknowledge our PI on this Center for Diabetes Translation Research, Dr. Deborah Hare-Joshu, and all of our colleagues down there in St. Louis. But really, as I said at the outset, the focus is about how to really understand more about the urban Indian context. And two of the things that I take away from this presentation, amongst the many, is a real need for greater awareness about the population of urban Indians, which is in itself, as you explained, very diverse, but really understanding. I've just really taken with the trends around violence that you highlighted, and particularly around PTSD in some of the diabetes work, and the need to focus around historical trauma. And that comes with greater awareness, I think. And when you have 8 manuscripts, published over a 10-year period in this arena, that does not lend itself to awareness. So, again, this is a step towards encouraging research in this area, encouraging collaboration and communication about our relatives in these regions. And I think the second point that I really take away is how critical it is in this context, as well as in the work that we do directly with tribes, to really develop appropriate processes of engaging American Indians in this context of urban populations, that also honor researchers' responsibilities. I heard you talk about the challenge, related to both the diversity of the urban population, but also the context of sovereignty. Here at the Policy Research Center at NCAI, we assert that tribes have sovereignty over research that happens on tribal lands and with tribal citizens, and that includes tribal citizens who live and move between urban and rural populations. So even though there's a challenge, I think, as you highlighted, absolutely about sovereign bodies, how do we think about our citizens and our responsibilities? And I really love that you took us through, the range of entities and organizations and actors who have responsibilities to put our heads together around addressing some of the needs and challenges to improve the context of health in urban American Indian populations. So thank you so much for that, Dr. Jamie and Dr. Nicole. All right, Caesar, I think you're going to take us through a few questions.
Yep, sure. We have a few questions that were submitted throughout the presentation in our questions box. Once again, if you'd like to ask a question, you can either type it in or you're welcome to raise your hand, which is underneath the option to raise a hand. So once you do that, I will acknowledge and unmute you. And then, of course, if you're going to do that, just please acknowledge who you are and if you're affiliated with any organization. But I'll go through the questions that were asked in advance. One of them is this only for urban areas? I guess the scope of this research and things.
Yeah, I mean, we really were focused from the very beginning on research in urban Indian populations. And again, as you, kind of goes back to the Tucson Indian Center trying to engage in some planning for research with their academic partner and recognizing that there might be an IRB issue that made it difficult for them to get approval for the research. So, while there may be things that we said that apply to tribes or that are just as relevant to tribes, yes, this was specifically focused on improving the quantity as well as quality of research in the health arena for urban Indian populations.
And I will just echo to say that we do have resources specific to research happening on with tribes available on the Policy Research Center website if folks have questions about that. The one that I would highlight is the Walk Softly, Listen Carefully, Building Research Relationships with Tribal Communities. It's available off both of the NCAI site and the NCAI PRC. But again, I think a lot of the themes that we heard today, while they are written in an urban Indian context, really do frame out some unique priorities for all of us working in American Indian Alaska Native research context.
Okay, great. Another question we have here is they're asking if there's a way you could provide the 8 articles that have been done over the past 10 years that you referenced in the presentation.
Yes, we can actually send that out. I'll send that to Malaya, and then if you can get that out, we can actually just send the citations.
Great. We'll include that in the materials along with the PowerPoint following this webinar as well. Thank you, Jamie.
Okay, and then we have another one for Jamie. It says, do we know how the number of articles for urban American Indians compares to numbers for tribal articles?
Well, I mean, when we first did the PubMed search, and again, if we had expanded our search engine, so there's a lot of other search engines that we could have used, but we did focus on PubMed because that's where any research that is supported by NIH and results in a publication, there should be an abstract in PubMed. So if you looked at the original, I don't know if you can kind of go back to that slide. It was the first slide we were talking about the knowledge map. But we actually did look at tribes and American Indian as one of the search engines, and you can see the difference. One more right there. Yeah, so when we did tribes and American Indians, there were over 4,000 articles that were generated. We didn't break that down further, but then when we did another search that was urban and American Indians, we actually got 343 articles. But again, we had to weed some of those out because some of them were outside of the United States, and some of them were concept papers, or there was a keyword that included urban, and American Indian was in the sample, but it wasn't focused on urban Indians. They may, a lot of times they'll say that they have an American Indian, they have American Indians in their sample, and and they may say, oh, well, it's 1% of the sample. When you weed it down, you find out it's really just one person. So those articles we also weeded out because that's not focused on urban Indian populations.
And I think, can I just add, I think something that's kind of startling about the quantity of studies, in PubMed is that, so even if we look at the 343 out of, over 4,400, right, it's less than 10%, but yet, we know that the number of American Indians and Alaska Native moving into urban areas is continuing to increase, and as of, 2010, it was at 71%. So given where the population is moving to, and yet the research is primarily being conducted in rural and reservation lands, the contrast is remarkable.
Okay. The next question we have here is, let me read it here. Is there a possibility of an IRB for all Native people for both on and off reservation? I know there are tribes already that have an IRB, but for tribes that do not have the means to provide this now, could there be a national IRB that could protect all Native people?
Wow. I think that it could be, wow, that's a great idea. I don't know whether or not, I don't know how that would work, because as it is now, if you are an urban Indian health organization or you're a tribal organization and you don't have an IRB, you can actually go through the Indian Health Service IRB. So I think that might be the closest to maybe a national that could be used. And so you would hope that through an Indian Health Service IRB process that it would be, culturally relevant, respectful, and all of that. Now, I think that if you did not have an IRB, let's say you were a tribe that didn't have an IRB, and you had a university partner, you could also use that university IRB. But I think the closest I could think of to a national IRB would be through the Indian Health Service, and they do have those mechanisms in place.
I want to follow up on that a little bit. We have heard from some program officers and agency leads at NIH and some other organizations about an interest in what they're calling a super IRB, which kind of follows along with this. And we've written some comments and provided some feedback that may actually stand in the face of tribal sovereignty. So we haven't seen a model yet that actually allows for and acknowledges tribal sovereignty. What we've seen actually work is at a different level of scope and scale, which is a regional structure. So, for example, the Montana-Wyoming Tribal Leaders Council has a research review process and board there, but tribes essentially opt into that. So it's important, although some of these regional bodies may assert that they have authority when more than one tribe in the region that they serve is involved in research. At NCAI, our step is to always honor tribal sovereignty. So tribes need to make that decision to either opt in or opt out to these IRBs and to these research review processes. So it's an ongoing conversation. I think, Jamie, you're right to point out the National IHS IRB. We've been in recent conversations with them, and they don't necessarily have their own forms and processes in place. They tend to review applications that have come through some other, either university IRB or otherwise, although they can serve as an IRB of record for tribes and tribal organizations. So it's a really important question, and I think part of it is driven by this desire to get more research through, but that also has to be checked by making sure that tribes are consulted and have appropriate sovereignty over research that happens on their lands and with their citizens from where we sit.
Okay, I have another question here asking, because this is about diabetes awareness, why is it that it is only urban areas and not tribal areas?
Well, I'll field that and just say that this is, as we said, one of 3 focused webinars that we're having on diabetes awareness, and this one is focused around the urban context because we do have significant populations who are dealing with health issues like diabetes. And as you saw from Jamie and Nicole's presentation, there is a great need for more research in this context of urban Indians, and so we wanted to provide some tools to researchers and those and tribal leaders and those working in the community, urban community context, to foster more research that way. So it's both and.
And I'm just reading through these, so if I, repeat the question too many times, you're also welcome to raise your hand and I'll turn it over to you. Here's another question I have. On FYI, I had inquired the IRB area office person and was told that it was a local study. It has to be approved by the local IHS. That sounds right?
Can you read it again, Caesar?
Sure. It says, FYI, I inquired the IRB area office person and was told that if it was a local study, it has to be approved by the local IHS.
So yeah, as I said, we've been.
I've actually heard that too.
Yeah, go ahead.
Malaya. I don't know if you've heard that, but I've actually heard that as well from a lot of different sources, that there's this idea that somehow if you receive funding from the IHS that you have to use their IRB. But we actually did find some narrative on the IHS website that basically said that you would use their IRB unless you had another IRB that you could use. I don't know if you know anything other than that, Malaya.
I have heard that piece as well, that if you have, you can either opt in or opt out. If you have another IRB, usually they will waive that, but we've gone through that process with them where you actually need to get a formal waiver. They have an opportunity to look through the IRB approval from another entity, but also we've heard too that if you're doing research in their clinics, then of course their oversight needs to be a part of that. So I think it's a question both of geography, right, in terms of local and them having the capacity to do that, but it's also if you're actually in the clinics, in IHS facilities, then they also have an oversight. So that would just be the other thing that I would add to that.
Okay, at this point we don't have any other questions submitted through the questions box. I guess we can invite any participants on the call. If you'd like to ask a question, you certainly can raise your hand and we'll unmute your line and you can ask any question you may like. Yeah, at this point, there's no one raising their hands. Is there, I guess, another last call, I guess, for any follow-ups to any questions that you may have submitted already or any points of clarification you'd like? You're welcome to raise your hand and we'll unmute your line. You can ask the questions directly if you'd like.
Caesar, I don't know if you, I'm just looking at the slide that you have up right now. I don't know if you could just scroll to the very last slide, which I believe has Jamie and my contact information. So if people do have questions that or comments or feedback that they would feel comfortable contacting us outside after this webinar, we do welcome such communication. So thank you.
Great. Well, I think without any further questions, I just want to highlight again, I want to thank the presenters. I learned a great deal from this, and I really look forward to the release of the manuscript. We will hold back the webinar. We will hold back the webinar posting the archive until the manuscript is submitted and our presenters give us the high sign on that front. But we will have the webinar archive and the PowerPoint as well as the list of 8 articles posted for you shortly. Okay. Looks like we did have somebody raise their hand.
Yeah, so I'll unmute your line. Okay, you are unmuted.
Hi, can you hear me?
Yep.
Oh, yeah, I just had a question regarding whether or not this could protect Native people, as if NIH has more strict policy on what is CBPR or what is considered CBPR, and would require more, I guess, a better partnership with tribal people or the tribes themselves.
I can speak to that in terms of our work here at NCAI. We've actually just finished a 4-year project under the NARCH mechanism, the Native American Research Centers for Health, specifically on that topic of CBPR. There was a concern that CBPR researchers and those familiar with it were kind of going into tribal communities raising that flag, saying, you know, you can trust us, we're using these approaches and these methods. And so there was just a lot of a need for information about how does CBPR work in the context of American Indian Alaska Native research in communities. And so we're hoping to put out a series of 4 or 5 manuscripts over the next 6 months or so based on what we found. We worked with, had both qualitative and quantitative research, both at the tribal level but also with communities of color. So looking at disparities and diversity in some different ways. And, you know, one of the just quick points on that we're finding is that the governance matters in some really important ways. So we're trying to develop some of these manuscripts to feature different approaches to research, oversight, and regulation, which definitely echo a lot of what we heard today on the call on this front. I don't know that I would say that NIH has more stringent kinds of roles, but we have engaged with NIH on 2 fronts. One, we put in some federal comments about a year ago. They asked for comments on relieving researcher burden, and we talked about the context of tribal sovereignty, and I'd be happy to share some of those comments. We're actually submitting again tomorrow, repeating many of those comments in regard to the NIH's draft genomics data sharing policy. So there's a lot of conversation about data sharing at the federal level. You know, President Obama has really fostered an open data administration, which I think is exciting on some levels, but is concerning, and we need to really be clear about where tribal sovereignty interacts with that open data approach. So we're working with NIH, but we do hope to have some products out there, both academic publications, and we are really trying to design a community-based rollout of policy briefs and toolkits on this front.
And I just want to add, I think one of the challenges I know in some of the discussions I've had, this is Nicole, is that you know, I think NIH and, you know, many of its program officers, and it's indicated in the funding announcements, are really having quite a comprehensive understanding of what CBPR is and the different characteristics and challenges. I think sometimes it doesn't trickle down to the reviewers, and so that has been a challenge. And as we saw in the case example that Jamie shared, is that in some cases the reviewers aren't sharing some of the same perspectives as you know, were indicated in the funding announcements or coming out of, you know, particular institutes. So really there's kind of a need of understanding at many different levels.
Really.
There's a quick clarification question asking what is genomics?
Great question. You can go to our genetics website, actually genetics.ncai.org, and we've got some great resources there, whole American Indian and Alaska Native genetics resource. Genomics is related to the study of genes and genetics. There's also pharmacogenomics and pharmacogenetics, which is about how you tailor medicines based on understandings of genetic profiles and maps of genes and DNA in some of that. So it's a bigger question, but we do have a lot of resources for tribes and communities at genetics.ncai.org that goes through it a lot more in detail.
Okay, and another question came in. A person was interested in working on a way to analyze effectiveness of an integrated team-based diabetes management program, and they're developing. And they're wondering, are there resources to help do that data analysis and publication?
Perhaps that's a good time to also direct you to one other website, which is http://CDTR for the Centers for Diabetes Translation Research, CDTR again, .wustl, WUSTL.edu. That's CDTR.wustl, which is Washington University in St. Louis, WUSTL.edu. And we do want to, as part of the CDTR program, let you know that we are looking for others working on research, working on intervention, particularly in diabetes translation. And through our center, we have resources which include up to 8 hours of review on applications and research from research scientists at Washington University and also here through NCAI as you shape some of these research interventions. We also have monthly working group calls through NCAI where we're trying to foster more works in progress of the scholars who are affiliated with our center. So there's our center, but as I mentioned at the beginning of the call, there are 6 other centers across the U.S., 2 others which are focused on American Indian Alaska Natives. So I'll highlight Dr. Spiro Manson, who's out at University of Colorado. They have a CDTR there through his Center for American Indian Alaska Native Health, and also University of North Carolina. Chapel Hill has a center focused there, largely on the Lumbee community in North Carolina. But again, if you go to cdtr.wustl.edu, you can find all of this information and information or access to resources that way.
I have another question, or someone raising their hand. Oh, okay, your line isn't, so feel free to ask your question.
Yes, I'm just inquiring in regard to you talked about the research capability of Native Americans. Are you looking at providing a education curriculum in regard to Native scientists?
A curriculum regarding Native scientists? I'm not sure I understand your question.
You identified in your presentation that there is a need for Native American scientists, and you wanted it to. Maybe I'm understanding wrong, but the education part and the research part I can't. It was on one of your slides, but you identified that there was a need for Native American scientists to do this research and academic. So I was just wondering if there was opportunity for that to be promoted in the education in our local community colleges.
Yeah, you know, I haven't thought about it in that context. I was really thinking around the NIH actually has programs to support minority scientists, and within that arena there's been not a lot that have been coming out that are American Indian. But certainly I think that it can be promoted in university programs. And one of the things that I find as I oftentimes will get PhD student candidates that are working on their dissertations or master's level students that are working on their thesis projects will come and ask for, you know, access to the urban Indian programs for, you know, accessing the people to participate in those projects. One of the things that I find really striking is the lack of training in research programs related to CBPR or any type of community-based and participatory methods. That seems to be, to me, that's one area that could really be improved. And I think that that would not only help any American Indian scientists, but would also be supportive of other folks that are working with maybe marginalized or disenfranchised communities. So if I were to make any recommendations just in terms of a starting place for academic institutions that are trying to grow scientists, it would be that foundational training in community-based and participatory approaches.
Okay.
I will also add that SACNAS, the Society for the Advancement of Chicanos and Native Americans in Science, as well as ACES, the American Indian Science and Engineering Society. We've had meetings with both their SACNAS's DC liaison, who's Dave Wilson, a Navajo researcher, and Sarah Echohawk, who's the new director of ACES, and both are very eager and interested in doing more around STEM development. And part of our conversation has been to really think in creative ways about the pipeline, that there may be a lot at the kind of high school undergraduate level, but there is definitely a need for more at the post-doc level and the early career faculty. That's where we also tend to lose a lot of our folks to private industry, nonprofit, which is not a loss to say, you know, we need people in all fields, but making sure that our American Indian Alaska Native researchers understand some of the resources that Jamie talked about from NIH, understand how to get access and develop R01 level kinds of research studies. There's, as many of you know, there's a whole pipeline and pathway And NIH has been great at kind of reaching out and making themselves available to showcase some of this, but it's an ongoing, I think, process. So it's a great question, I think, about curriculum. At this point, I think we're really trying to think collaboratively across organizations about that pipeline and where are those gaps, where are the kind of the leaky pieces of that pipeline that we can supplement in different ways. So it's a really important question.
And then Ms. Marcellus, I'm sorry if I mispronounced your name, Ms. Marcellus. You had another question about funding available. Does that tie into what you already had asked?
Well, I did ask in regard to the student aspect, but I also am asking in the research aspect, is there, and I think that was answered already, I'm not real sure, but if there's any funding available for the research aspect of studying on the diabetes and, you know, getting it all set up and providing protocols to the local communities. In fact, that's kind of where I'm hoping that that's why I'm on this webinar today, because I called one of the ladies. I just happened to receive the webinar today, and I thought, well, this is a good opportunity to find out what's going on out there, because diabetes is one of the main sicknesses in our communities, and cancer follows not too far behind. And we live on a 6x12 reservation, and in our community we have a 12-bed dialysis center which houses on Monday, Wednesday, and Fridays 31 individuals, and that's from 6 a.m. to 6 p.m. And of those 31 individuals, 27 of them are Native American. And I mean, that's a dialysis center because they are diabetic and their kidneys are failing them. And you know, my heart goes out to this area because my father was a diabetic, and because of complications with his diabetes, he left us. So you know, this is where my heart is, and I guess I'm just trying to find out if there's any way that we can obtain research funds to assist in getting our local community at least, you know, a study done based on some kind of intervention that we have, that I'm hoping would be a possibility to be supported by our local IHS and our tribal government. So I'm really excited about this because I see very, you know, I see hope, and that's kind of what why I'm here today, and I thank you for all of your information.
Thank you. Look forward to following up with you.
At this point, all questions have been addressed, and there are none raising their hands.
Okay. All right. Well, I do want to just close again by highlighting we've got 2 other webinars as part of this series. As I mentioned, this coming Friday, from 2 to 3:30, again, same time, Eastern Standard. We've got Dr. Tassie Parker, who's Seneca out of University of New Mexico, going to be talking about cultural humility in the research process, and she's going to be giving some great examples from her own work around community health assessments and diabetes prevention work. And then on Tuesday next, same time, 2 to 3:30 Eastern Standard, we have Dr. Rodney Herring, also Seneca. He's out of the Cattaraugus community in New York, but he's a University of Arizona researcher as well. And he's going to be talking about philosophies related to indigenous knowledge, tribal perspective in informing translation at the T3 and the T4 level in diabetes. So again, I want to thank our wonderful presenters for kicking off our series around Diabetes Awareness Month and the Center for Diabetes Translation Research, Dr. Jamie, Dr. Nicole, and as I said, excited to see the manuscript. So hopefully you got some good feedback today, but thank you all for joining us on this webinar.
Thank you for this opportunity. Sorry, Jamie.
It's all right. Thank you, Malaya. We really appreciate it. Have a great day.
Take care, everyone. Goodbye.
Bye-bye.
Thank you. Bye-bye.